Please
A
go.
very good evening to all the members of the Bombay Orthopedic Society. On behalf of the Adapt and Evolve webinars, I invite you to a very special Adapt and Evolve webinar on this beautiful cold Sunday evening. It's a very interesting topic, essentially related to COVID and our practice. And the speaker is Dr. Vivek Tilwani, who's a dear friend, a medical legal expert, and a general surgeon who is honorary professor of general surgery at the Sir J.J. Group of Hospitals, in addition to being attached to multiple private hospitals in the city of Mumbai. So without any further ado, I now call upon the Honorable President of the Bombay Orthopedic Society, Dr. Sangeet Gawale, to give the welcome address and the introduction of the speaker.
Good evening all. Today in this session on Adapt and Evolve, we have Dr. Vivek Tilwani, who is an expert in medical legal issues, which are related particularly to the surgical sides. And we have taken his help a lot many times. He has also been as one of the speakers in, I think 3 years back, if I'm not wrong, Swapnil.
And he's spoken multiple times.
Yeah. And he's an excellent orator, and he has a profound knowledge on the issues which are related to the complications we have related to the medical legal aspects, particularly in our field. And today he is going to talk on what is related to COVID, what we have gone through in these 2 years, how that is going to affect our future if there are any medical legal issues. So he's going to address about that. Further introduction, I would request Swapnil to introduce him.
Yeah. So Dr. Vivek is a medical legal expert, though he's a practicing general surgeon, but his family has a law firm essentially in South Mumbai. He is an expert on medical legal law and has represented a lot of doctors, in fact, even out of gratis, for the sake of the fraternity and for the sake of the society. And it's absolutely a pleasure for us that he has been a faculty at multiple meetings, medical legal meetings of the Bombay Orthopedic Society, as well as in YROC. So I welcome Vivek today, and I request Vivek to kindly start the proceedings.
Unmute
yourself.
Unmute yourself.
Unmute.
Sorry. Thank you, Dr. Gawale. Thank you, Swapnil, and a very good evening to everyone. I'm here to bore you on a Sunday evening, literally to sing a lullaby so that everyone gets good sleep. If you get good sleep tonight, please thank me. So I've been asked to speak on COVID-related issues in the medical legal scenario. So that's exactly what I'm trying to focus on. And this is my best slide. I always start my medical legal talks with this. The concept of medical legal issues is always viewing medicine through the eyeglass of the law. This is put in the simplest words to understand that we normally follow medical protocols. But when we are tested in medical legal issues, we are tested with reference to the provisions of the law. In short, we are expected to be correct both medically, scientifically, that is, as well as legally. And then you are out of the entire ambit. All of us know what COVID is. I'm not going to waste your time saying what the virus is, where it started from, etc., because all of us have heard multiple things about it. Not only that, we've all got introduced to the virus in some form or the other. One of us has either contracted the virus or some close person or some patient. Somewhere or other, we've all got introduced. So we don't need any further introduction to the virus per se. We need to be introduced to the laws. We have something known as the Epidemic Diseases Act 1897 and the Disaster Management Act of 2005. These two acts together give tremendous, extensive and sweeping powers to the state authorities to literally take any sort of action for the prevention of an epidemic disease. We must be aware of this act. Of course, It is always for the prevention of the spread of this disease. Under that GAB, no other action is permissible, but there are sweeping powers. We also have the biomedical waste management rules, which are under the Environment Protection Act of 1986. The rules are of 1998, which are equally important in the COVID scenario. But then we tend to forget that when we talk of medical legal issues, we have certain key areas of litigation which exist in the pre-COVID scenario and which hold good even today. We always tend to forget, when we look at COVID, we forget each and every common cold and flu. We just look at everything as COVID, and the same mistake is what some people make. Let us talk about COVID related issues, but we need to remember the other issues as well. The first issue is consent. Now, consent in the medical text is what is defined here by me. But when we look at consent from the COVID point of view, we must remember capacity, knowledge, and voluntariness are the key ingredients of valid consent. But we also have informed and real consent, which is a different issue. But remember, consent should be revised from the COVID-19 perspective. We've had a couple of cases. Now, this is not hypothetical. Our firm has handled notices received from various patients to doctors where there are allegations relating to COVID in surgical cases. This is a fact. It's not a very high figure, but there are people who have alleged that, look, you have taken me in a setup where there were COVID cases, but I was not informed that COVID cases were kept under the same roof. Therefore, though I haven't got COVID, there was a risk to my life. We've had a case where there was a case of cancer of the breast. The patient was taken up in a non-COVID area, that is a non-COVID institute, not only area. Patient was RT-PCR negative at point of admission. Pre-operative CT scan, HRCT of the chest was done to rule out COVID, and post-operatively, the patient tested RT-PCR positive. Of course, there were no medical legal issues which followed thereafter, but we've had these kind of scenarios. Now, in today's scenario, the doctor-patient relationship is not what it used to be 2000 years ago in ancient India, where the doctor was, virtually a form of God, and he was divine and he was worshipped, and the doctor never did anything wrong in that concept. Today's doctor is more of a contractor. If you call me to paint your house, of course, I'll do a terrible job as a painter, but if you call me, all you do is select the paint and I'll put it. And if it doesn't look good, it's not my responsibility, it's yours, because you selected the shade. That's how the work of a contractor goes. Much to that, today's patient gives consent, you operate. And to a certain extent, the responsibility of that consent lies on the shoulder of that patient. It is better to be clear to the patient that, look, though you are in a non-COVID area, all precautions will be taken, but there are cases where COVID creeps in from anywhere. You could be in a window period, a healthcare worker could be in the window period, and you could contract COVID merely because you have come in contact with someone without being identifiable with respect to the source. And therefore, unless you are willing to give this kind of consent, we cannot take you up for surgery. It is better to be clear in these points rather than face a litigation later on. Training and SOPs for healthcare workers. There are various types of PPEs for each level of work, and SOPs for that have to be drawn clearly. Training and SOPs for healthcare workers with respect to donning and doffing, disposal of used items, etc., even the entry and exit sequence, patient route for transportation, an efficient infection control committee, etc. All these need to be looked at. Remember, these are looked at on the screen right now. God forbid, if any of you ever face an allegation of what I mentioned, if you can document that all this was done, you will be amply safe in a litigation. All you need to show is that all this was done. These are not mere points, but these would be required to be proven in a legal manner. Yes, I did this. I followed entry and exit sequence. We had a predefined route for transportation. If you can prove all this, you're much safer. As I told you, today's doctor and patient relationship is a mutual contract. Contracts are always mutual. They are never unilateral. But I've emphasized on the word mutual because a patient selects a doctor and the doctor accepts the patient. Please remember, a doctor can withdraw from a patient after giving notice saying, excuse me, I do not wish to treat you any further. Of course, there is a rider to it. You can't withdraw in the presence of a life-saving emergency. You have to give adequate notice to the patient that you would not like to treat him and that he is free to seek a medical expert of his own choice, and you'll hand over the case. But all the more, in the midst of a COVID scenario or a pandemic, if the doctor or any healthcare worker is put to risk by a patient because the patient is irresponsible enough not to comply with certain practices which are standard, it is a good reason for a doctor to withdraw from the treatment of that patient. You have a patient who refuses to wear a mask and keeps coughing in your consulting room. You have every right to ask him to leave and not step back in, provided there is no life-saving emergency where your role is crucial to save his life. Otherwise, save his life and then ask him to leave. Emergency admissions, we all know about triage. We all know that rapid antigen test is done. We all know about RT-PCR. We must consider about a role of a screening HRCT even if the patient is a proven negative case, especially in those where you have symptoms of breathlessness. This will go a long way to protect a surgeon as well as medically screen out a patient, because RT-PCR may not always test positive, but HRCT is an equally reliable, if not more reliable, tool. Isolation of patients who test positive and reporting of cases to the authorities. Of course, this is more of the legal part. We must have pre-operative SOPs in place. A COVID inclusive consent would be mandatory. Social distancing, anesthesia checklist, surgical checklist, nursing checklist. We must have checklists for all this so that we don't skip out on anything. These checklists should be preserved in the document, in the file. If you ever have an allegation, these checklists will go ahead to help you. In the operative part, the concept of an operation theater before this COVID scenario was always the generation of positive air pressure inside the operation theater, so that when you open the door, air rushes out. It's sterile air, but non-sterile air doesn't enter the OT. This entire concept has been reversed by COVID, where now we are required to prefer negative pressure instead of positive pressure. HEPA filters are also useful. Surgeons are advised to enter the OT 15 minutes after intubation. Short duration of surgery, lengthy procedures should be avoided as far as possible. One important thing is minimal access surgery, especially laparoscopic surgery, should be avoided because concentrated viral aerosols are found in pneumoperitoneum. So these surgeries are best avoided. Don't go for a laparoscopic cholecystectomy in the midst of a pandemic. Please avoid it. Exit sequences to the reverse of entry sequence. Surgeons are VIPs. They come in first, last, and leave early. So that sequence COVID helps us. In case endoscopic surgery is deemed essential, small port incisions are advised because gas leakage around the port would spread aerosol-based infection much faster. Low CO2 pressures so that you have lesser insufflation pressure and leakage. Suction and smoke evacuation should be very proper. Desufflation should be proper. Aerosol inducing agents and equipment should be avoided. For example, electrocautery, USG scalpel should be avoided. In case of atelectasis, pneumonia, thromboembolism, etc., post-operatively, always try to rule out COVID infection once again, even if the patient had tested negative. Shorter hospital stay, is advisable. Follow-up on telemedicine is advisable. Now, in case of deaths, what do you do? Reporting, certification, corp management, and body disposal. Proper SOPs are required to be maintained. And this is the importance of record keeping and documentation. We have had cases, like I told you, one reply was sufficient to settle down the matter, just because the documentation of the hospital was proper. Though there were COVID-related allegations, the matter did not proceed to a litigation because a strong reply was sufficient. Some strong reply could be generated only because the documentation of the hospital and the doctors was proper. If they lacked the documentation, no one could have generated a strong reply for them. Everything that was done was justifiable, and therefore the matter did not land up with litigation. It was closed at level of a legal notice. Now we have to understand that we have to weigh the legal implications of delayed treatment. As I said, when we talk of treatment, surgical treatment, especially in a COVID scenario, timely treatment and safety of healthcare workers both have to be weighed. So purely elective cases are better avoided. It is a surgeon's decision, and the surgeon will be the only right man to decide what is emergency, what is semi-emergency, what is elective, and what is avoidable. We cannot list it out here, but so long as you find some procedure avoidable, please remember you're much better off not doing it in a pandemic scenario. Overexposure and burnout of healthcare workers are equally important. As a doctor and as an institute of medical care, you are not only responsible to your patient, you are responsible to your employees, your institute, to society itself to avoid spread. And as a human, you also have one responsibility towards your family members, that you don't carry something home and gift it to them because you were accidentally exposed. All these legal implications come on to the question of delayed treatment. Treatment should not be delayed, but when non-surgical remedies are equally effective, they definitely can be denied surgical access. With this, I've come an end to my short talk. If there are any questions related to this, I would be more than glad to answer.
When do you suggest to operate select non-emergency cases like total knee replacement, total hip replacement, elective?
To be very honest, I would say that when there are a high number of cases and in the midst of an upsurge of cases, all elective cases are best postponed till such time that the situation comes under control for multiple reasons. One reason is that you could get accidental exposure. Second reason is that your institute would already be highly worked up. Third thing is patient comorbidities would be an equally important factor. And a comorbid patient could contract an infection and develop complications much more than an ordinary, normal, healthy person. In case your patient develops any comorbidity, ultimately, it is going to be your liability, and ultimately your patient is also going to suffer. So I would advise postponement of purely elective surgeries till at least a time when you find it safe to operate.
The second question is, COVID consent form, have you made separate, or can we add that patient can develop COVID following surgery?
See, whether you add it separately as a separate COVID-related consent form and obtain their signature, or whether you add it within one common consent form, is a mere question of formality. The importance is that both these things, the regular consent as well as the COVID-related specific consent, must be brought to the notice of the patient, and the signature of the patient must be on it. You take it separately, it's all right. You take it within your common consent, it's all right.
Okay.
Legally,
Thank you.
the patient will not alter.
Thank you. Thank you.
Vivek, I wanted to ask you, see now in the recent past, as per the ICMR guidelines, for a routine surgery, a COVID test is not mandatory. And having said that, just like the discriminatory kind of practices which used to happen for the seropositive patients, I think the law and the government is a little skeptical that if at all testing is done, then there can be discrimination. So what exactly is the law, and what is the legal standing, and how do we keep ourselves safe both from the medical perspective and from the legal perspective in this situation?
Yes. Now, the first thing is, when you say that you should operate on a patient without testing and screening, these guidelines have come up because we have suddenly encountered a so-called species. I'm calling it a species just to label it as an individual identity. The species is called Omicron, and it was realized that the mortality rate is not very high. In the first wave and the second wave, there were no such directions because mortality rates were comparatively high. God forbid, if you are to suddenly come up with a variant which has a horrible mortality rate, these guidelines will not help you or hold true at all. Now, this is one point. Second point is, irrespective of whether or not you consider Omicron as a low mortality disease, even if it is 1%, you still are likely of spreading it to that 1% of society, because this is a novel virus. We call it novel because we really don't know how it behaves. It is a much safer practice to be sure on what you are operating rather than land up with an allegation. आपके पास ऑपरेट किया, उसके बाद कोविड हो गया, पहले तो कुछ नहीं था, वो आपके पास आया, बाद में खांसने लगा. So one, please take all COVID-related precautions as universal precautions. For HIV, when they said stop screening, they said you take universal precautions. Now they ask you again to take universal precautions and then not discriminate. I repeat, do not discriminate. But under the garb of discrimination, please do not put anyone, including yourselves and your colleagues, at risk. This is something which would not be legally correct, and it would also be tantamount to a sin, not only an offense. It would be a sin to expose anyone to a disease.
Vivek, continuing to his question. Now,
Yes.
as per the set guidelines which were released about 8 to 10 days back, I mean the BMC I'm talking about.
Yes.
It is not mandatory to do a pre-operative test, right? But the hospital, the private hospital, they do not admit the patient without a test. Now, where do we stand legally as a surgeon or a consultant under whom the patient is going to be admitted?
See, point number one, if you have a guideline is not at par with a law. You may get a guideline from someone, but that is not equal to a law. You may give it the status of a law to follow, but it doesn't replace the law. Most important thing is, in the midst of an epidemic, anything which has to be done to control the spread of a disease. This is of utmost importance. So if there is a screening, these guidelines have come up because Omicron has come in. If you had a higher mortality rate, and you can still get one, the same guidelines are liable to be changed. As of now, if you operate and your patient gets infected, suffers something, ultimately what happens? So a screening is important. Please follow the guidelines of the DMC, but remember that the guidelines merely say that don't blindly screen merely because you're operating. but there are other medical indications to screen as well. Those indications cannot be neglected. Follow
And,
the indications.
Yeah, Neeraj has a question in a chat box, and his question is, does the consent be in the language of the patient, and should we get a written consent of the expected complication if it turns out positive in the hospital?
The consent ideally must be in the language of the patient. Obviously, we cannot learn all languages. So if we don't have that language, we can explain it to a language the patient understands, or have a translator who can then sign over there. Has considered this aspect as well, that the translation has been done by this person. For example, if the consent is in Telugu, I don't know it. And let's say, Swapnil, sorry, but yes, you know Telugu, and I have you with me. You sign that I have translated this into Telugu and explained to him. This will be a much more safer practice. Regarding whether complications of COVID should be explained, yes, under the doctrine of consent, not only the complication, but all possible outcomes of the complication must be explained in writing. So you have to explain, in case you get COVID, these possible outcomes are also there. That would be COVID-specific consent.
There is one more question related to the same topic, whether there should be a video consent.
Video consent is a very desirable way of recording, but you need that much of electronic space or cloud space to preserve that record. It is very much reliable as evidence, though there are procedures under the Evidence Act to rely. There are procedures to be followed, but you can definitely use it to demonstrate that consent was taken, and it will be valid in a court of law, provided you follow the practice which is established under the Evidence Act.
Sanjay, your question first, and then we go to Harshad.
Yeah, thank you. My question is basically what so far Dr. Vivek has told looks a little vague to me in a sense. Sorry for this word. But see, in orthopedics, we are sort of having semi-emergencies, like an IT fracture, distal and radius. As soon as the patient comes, within 6 hours, he's labeled as positive. And then we sort of shift him to the COVID ward, and then we wait for this to get negative. But patient is not actually, if you really ask me, they're not bothered who else gets it. They want their surgery to be done as fast as possible. So then we have to give them reasons. No, this is COVID, you will get complications. We never tell them that I will get infection. So it is very difficult to tell that I will get infection or the staff will get infection. Because in last 2 years, I have noticed no patient has said that, no, that is really true. So what is going to be the right? As you said, guidelines are not going to work. What BMC says is not going to work ultimately in the court of law if somebody gets infected. So what is actually the right thing to do in such cases? So they are not ready to wait for 7 days when they get, sometimes they even, even after 10 days, they get CB-NAT is positive still there. So yes. What is the right thing? Why we save ourselves also, as well as give treatment to the patient who is waiting genuinely for his treatment?
Right. So now it's a very good question, very interesting, and I'll try my best to answer it to your satisfaction. Point number one, the moment you tell me that there is a generalized infection, why talk only of COVID? If you are going for a very clean surgery, even urinary tract infection is something that you try to screen and rule out. Want to operate on the patient. You know this very well. Why? Because you don't want a septic focus. COVID can generate pneumonia, can induce any sort of lung complication, can induce thromboembolism, can induce a stroke, can induce cardiovascular symptoms, can induce respiratory symptoms, not only to you, but even to your patient. And you really do not know which of these will actually occur in the postoperative period in case of your own patient as well. Explain these to the patient. Tell them that since you have COVID, your lung also could be damaged. Not only that, post-op surgical stress also could contribute to your lung damage. If you feel, honestly, medically speaking, in good faith, if you feel that this is not a fit case to operate, please advise them that this would not be a suitable case to operate. See, finally, the concept of consent also says that you discuss all possible modes of treatment and their outcomes with your patient. But to the end of it, you advise the best mode which you feel is proper for your patient. As a medical consultant, you are well within your rights to advise the patient one way or the other with respect to each and every possible mode. I'll give a small example. Let's say a patient has a Colles fracture. Patient is a young 10-year-old boy who's fallen down while playing and got a Colles. A very simple example I'll give you. Some person may feel that plating would be a good option. Some person may feel that just simple closed reduction and a cast would be a good option. What would you advise? I'm sure there will be a different, option or opinion available from 2 or 3 different consultants, but each of them will base it on their experience and good faith. Please do the same thing. If you feel that the patient should not be operated at that point of time, be firm on it and tell them, I don't think I should operate on you right now. I am not satisfied myself that you need surgery, and in that scenario, I can't operate. There is a difference between consent and a hotel menu. You tell the waiter, I want tea, he has to give you tea. He can't tell you, excuse me, I don't think tea is right for you. But a patient cannot dictate you on consent. You can give him 3 options, though the other 2, according to you, are not viable. You can tell him, I will not do this for you. You want it? Please go to someone else. I am not satisfied that this has to be done, so I will not take this as part of my consent. You are well within your rights so long as you are guided by standard medical principles.
Vivek, the same situation Dr. Sanjay Dar has explained, where patient has a hip fracture. He turns out to be positive in the casualty or after getting a day's admission. And now we are shifting to a COVID ward.
Yes.
Or discharging him. Now,
yes.
Is this 1 day expense, or if he's in the COVID ward for 7 days, is it covered by the insurance?
There was a point of time where I would have been able to answer this insurance question much better a couple of years ago, because there was something known as a standard insurance package. Now the insurance company gives you a cafeteria approach. You want a family cover, you want this cover, you want that cover. Each insurance cover has a different kind of, escape route, loophole, and a coverage provision. So it would not be possible to put it as 1+1. But yes, most of the insurance covers would be obliged to cover this period of hospitalization, barring a couple of types of policies where they can escape out. Most of them will be covered.
Okay. And there is a question in the chat box. I think Agnivesh is trying to ask, what is the appropriate time to operate? Like today, if he is positive, so whether it is 5 days, 6 days, 7 days, or we repeat and then operate him.
See,
is that right? Agnivesh, are you there?
Sir, that was by Prakash Saman, sir. That question
sorry,
is by Prakash Saman.
See, the guidelines, I repeat, are merely that don't screen for the sake of screening. The guidelines have never said don't screen in presence of medical indication. The moment you tell me that this patient is positive, I am not sure if the patient will obviously be negative at the end of a 7-day period. We have had seen cases where even after 12 days, patients have tested RT-PCR positive, that too with a low cycle threshold, which means active infection spreaders, even at the end of 12 days. If you operate in the midst of this, you might land up with a cardiovascular complication for which you will be held liable ultimately, because ultimately you are the captain of the ship as a surgeon, as they used to conventionally call you. So I would strongly suggest that if there is a history of the patient being positive, please screen the patient, because there is a medical indication. Surgery is not something you can just do away and get away with it. There is a lot of responsibility attached to it. Looking to that, please screen the patient. And once the patient is RT-PCR negative, wait for at least 3 weeks if there is no medical emergency.
Harshad, your question.
So my question was actually an extension of what Dr. Sanjay Dhar said. I have two questions. The first part you've already answered as far as when to operate if a patient turns out positive in the ward. My question is, if we delay the surgery, say for 15 days or maybe more than that, and there is, then the patient turns negative and then you operate on him and you land up with some problem related to delay in surgery. It's not just that you operated it wrongly. It's just that it was not operated on the right time because of prevailing circumstances, COVID positivity, etc. Does the liability rest on you?
I always say resuscitation saves the patient. Documentation saves the doctor. I'll answer this question in a small indirect manner and you'll get exactly what I mean. You have a patient with severe chest pain and breathlessness who comes to the casualty. What do? You resuscitate. He doesn't revive, you can't revive him back. You give intracardiac adrenaline, you give cortisol, you give everything, you intubate. Finally, with DC shock, you revived the patient. Well, many of you may have seen this scenario somewhere in the ICU or in the OT. You see, you have a sigh of relief. Chalo, patient bach gaya. If all this is not documented, legally speaking, if he goes to a court of law, doctor did nothing. See, the file is blank paper. I was breathless. Nothing was done. I was ignored. And you will have to even pay compensation in a consumer court because you've done nothing technically.
Yeah.
So all that has been done has to be documented. Each and every day of delay must be explained in the indoor file. Patient examined, patient has tested positive, medically not advisable to operate. Please rope in a physician, let a physician also opine, rope in an anesthetist, and let this be documented that medically speaking, it is not advisable to operate right now. So long as your findings are footed on strong medical grounds, no court of law will rule anything against you. But you do everything, but you don't document it, you are open to all attacks. Documentation saves the doctor, resuscitation only saves the patient.
Vivek, in relation to the same, patient
Yes.
is shifted to COVID ward
Yes.
under somebody else. Are we supposed to see the patient daily, legally?
The patient is under someone else.
Yes.
If the
It's
patient
transferred under physician for
if
a
the
COVID.
patient is jointly under you and the patient, you are bound to see him every day. If the patient is under someone else, in a COVID scenario, you are also supposed to minimize exposure to everyone. The patient is in isolation. So unless you are required, you do not need to see him every day. You can specifically give it in writing while transferring to the physician that I will be willing to see the patient as and when called upon by you. Put it in writing, let the physician sign that. And then whenever he calls you, you can go and see. But if you feel that the patient medically has a tendency, here a lot depends on your finding. If you feel that the patient has something, like I'll give you an example, there's a fracture of the vertebra, you need to see whether there's a neurological deficit developing or a fracture of the radius or ulna, whether a vascular compromise is developing. This is something a physician will not be able to see. You'll require a person who is experienced in ortho to see this. If you are suspecting something like this, then you will have to go every day. It will depend more on the presentation of the patient and on the condition of the patient rather than merely saying, do I need to see him every day?
Sir, one last part of the question. Sangeet sir, with your permission.
Yes. Please go ahead.
Now that the government has declared a pandemic and pandemic is a law, I mean, in the sense the law of pandemic prevails, is it necessary that we have to tell the patient you can get COVID in the hospital or you can get COVID post-op? Because it is a known fact now that anywhere in the world, anywhere you travel, you can get COVID. You don't take consent while traveling in a train or in an airline that you'll get COVID there. So why specifically for a hospital?
For an airline, there are specific guidelines. Take 2 vaccines, have an RT-PCR negative, enter the area, and then if you get it, it is at your peril. In a medical area, the patient will say, this is a field which concerns special knowledge, which I did not have. My doctor had it. I consulted him. He kept me in the dark. If the doctor keeps you in the dark, it is a ground open to attack. It is better to be safe than sorry. From what you have said, you can advance this argument in a court of law. No doubt. If you haven't taken COVID consent, you've operated, and if you land up with this kind of a disaster, This argument can be put up, but if the judge is not convinced by your stand, you will be asked to pay. But if you can establish that you had explained all this in advance, you are much safer.
Say one more thing, doctor. As you said that the physician will transfer the COVID patient on his side. Suppose if
Yes.
it's a fracture neck, femur or whatever. But most of the time nowadays what happens is, as with this Omicron, they said that the chest involvement is not there, the X-ray chest is clear. And there is a layout guidelines for the new COVID treatment now with Omicron. And they don't transfer the patient and they tell that you treat the patient and it will take 5 to 7 days time and they refuse to transfer. You treat in your side because no special treatment of physician is required. In that case, what will you do? Because suppose if he does not transfer, so you are bound to see him daily and do what?
Now, the question is, if you feel that this is a patient not for your specialty, you can take the management into the loop and ask them to have the patient transferred. You have the option of seeking transfer to another physician. But this does not give you the right to operate if you're not satisfied that this is a fit case to operate. If the patient is not fit for surgery right now, just because a physician refuses to admit him on his side, it doesn't make him fit to be operated. If you are satisfied that the patient should not be operated on medical grounds, please be firm on your specific advice. Regarding transfer of the patient under a physician, this is more of a hospital administration related aspect. As I always say, the patient comes to the hospital or to a specific doctor. Like a patient says, I want XYZ hospital. So long as he's there, he's not much concerned of which doctor has actually treated him. So long as he's fine, he's good with it. There are some patients who specifically say that I want this doctor only. In any event, you can, as a consultant, specifically interact with the physician, argue out the matter and say, look, this is a case which is a physician's domain. It is better that you take it or let some other physician come in. You will have to rope in a physician.
More thing, suppose nowadays with the online consultation, video consultation, whatever, what is the medical legal liabilities for the consultant? Because here we don't touch the patient. We just take the complaint and like a Google, we advise them.
Yes.
So in that case, in that case, suppose if somebody has a backache, I can't check the SLR there or a neurological or anything there. So clinical, there is nothing, just empirically I am giving some treatment for any of our doctors. So are the doctors medical legally can be means they are liable for this medical legal action?
Yes.
Vivek, before I just want to add something to this, what Dr. Deepak has said, is that when we send out these prescriptions of online consults, do we have to put certain things like caveats like conditions apply or something of that sort inbuilt in our prescriptions so that we are safer from the medical legal perspective?
See, whether you give an online prescription or a physical prescription, the liability would be almost the same. For certain medicines like Schedule H and those medicines, if you are into giving those kind of medicines, it is better to specify that only the fixed quantity should be issued, because you don't want a patient going and taking Gardinol or diazepam tablets from chemist A, producing the same prescription and going to chemist B, producing the same prescription and getting alprazolam from chemist C, and then gathering a huge stock at home. So it is a safer practice to use that kind of a caveat in giving such cases. On a multivitamin, you really don't need to do that. It again depends on what you are prescribing. In certain medicines, even the FDA has given directions that you have to issue a prescription in 4 copies. 1 copy goes to the pharmaceutical company, 1 goes to the chemist, 1 to the doctor, 1 to the patient. So unless the patient produces 4 copies, he really can't get the medicine also. You can keep such caveats, but then those caveats would even apply to a physical prescription, which is given offline, as we call it. There's no real difference in the two, except that an online can go on, they can go on and on printing the same thing.
It's not from the prescription drugs I'm saying. It's the treatment basically which is offered. See, I get a patient who has got a wrist injury. I ask them to get an X-ray done. He sends me a report. He doesn't send me the film. The report is reported by a third party sitting somewhere else who doesn't see the patient, and it is reported as normal. And I give the patient some crepe bandage, he develops a malunion. I'm just talking about a hypothetical situation. So, I mean, what is the advice and what is the medical legal implication?
One thing is, if the patient has not sent you a film, it is better to ask him to send a copy of the film across to you. Because if I say, you told me you had a knee injury after a fall, so I did not look at the head. Ultimately, you are looking at the entire human body. So you are expected to look at everything head to toe. You may have a case of defense by saying that I had restricted access to the patient and records. No doubt, a certain amount of liability will be nailed onto you for not seeing the film. Who had prevented you from seeing the film? If you've not done something, you must demonstrate that you were prevented by circumstances from seeing it. If you have been writing for the patient that he has lost the film and hence he is not able to produce it, therefore he's shown you the report, record that in your findings that I've asked for the film, the patient has mentioned that he's lost the film, hence I didn't have access. You will be safe. But if you say that he didn't send it to me, what prevented you from asking for it? This is an answer you can't give. So on this ground, you will still be nailed for it, though partially. It is safer to view the film. It is safer to ask for whatever documents you want. Telemedicine and teleconsultation have been permitted in this COVID scenario by a special change in the Medical Council Ethics and Practice Conduct rules, no doubt. But they have their own demerits for which you shouldn't allow yourself to be hauled up. I'll give a surgical example. If I get a case of pain in abdomen, I would never give a painkiller to the patient because there's a dictum in the textbook that we should never give it. Then I would insist that the patient comes before me, gets examined, and only then takes treatment. So these kind of things will have to be looked into before you actually take the step of giving a medical consultation on the basis of a video consultation alone. It is up to you to rule out each and every possible risk which is foreseeable before you give a prescription of clarity in an online consultation. That onus is on you because you are omitting certain parts of the medical treatment guideline. Unless you are satisfied that you're doing the right thing, insist that the patient comes for those particular things.
Nivesh?
Yes, sir. One just quick comment to what Vivek sir was also saying, that the latest guidelines which have come out on the telemedicine, they tell the doctor that two immediate responsibilities what he has. One is to introduce himself to the patient, check the ID of the patient, and third, immediately assess whether the patient can be seen in an online consult or not. If any point of time you feel that the patient is not fit for an online consult, please withdraw immediately.
Yes.
And one small question to you, Vivek sir, is that whatever discussions you said that we should document in the file, is it necessary that they need to be countersigned by some of the patient relative or somebody from his side also?
See, insofar as you have written about your medical findings, there is no need for their countersign. If you say SLR, if you say this is grade 3, if you say there is no tone, there is absence of tone, these are medical findings for which no signature of any patient or relative is required. Patients and relatives sign will be required when you have explained the thing to them. So I'll give a small example. You have a patient with radius and ulna fracture. You feel that there is a vascular compromise. You have examined, you found that there is a dusky palm. Inform the relatives, take their sign. I have been informed that by the doctor that his findings are that there's a dusky palm, there's absence of pulse, there's so-and-so, cold, clammy, extremity, blah, 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 blah. And he has explained to me that these findings mean that there is a vascular compromise, which means blood supply to the hand is lacking. And this could lead to the following: loss of limb, loss of etc., etc., etc. The treatment for this would be A, revascularization, 2, thromboembolectomy, 3, blah, 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 all the way till amputation, all the options. But your daily notes do not require their countersign because they don't even understand what you've written.
Vivek, there's one more question which I think
Yes.
a lot of people may not ask.
Yes.
This is regarding the payments and the remuneration. Now, I think there has been a capping which has happened. I'm not sure if it is on surgical charges. It's definitely on intensive care and all these things. I'm not really sure about surgery, but see, on one side, there is a risk of life to a surgeon when he's operating on a patient during the pandemic. And on the other side is this thing about not trying to have these, what do you call as, a situation wherein you are trying to get too much money out of a patient. So what does the law say about this? And is there any sort of a thing in the law where the patient can say that, I was charged over and above what I was supposed to be, and the surgeon was predatory in his treatment?
Capping usually is by way of an order passed in exercise of certain powers vested in an officer or an authority, which powers are vested through the law. The concept of capping is that you can't treat the patient as a prey and yourself as a predator. You are not a lion and the patient is not a goat in the forest. There is something called as human society, and you must be fair to society. You as a doctor are entitled to your professional charges, no matter what that be. There is the freedom to practice your profession in the supreme law, that is the Constitution of India. That is taken as the supreme law of India. Any law is subordinate, any act is subordinate to the Constitution. So any act which comes in conflict with the Constitution automatically gets eclipsed, as we call it. There's a doctrine of eclipse. There's some sort of controversy. The Constitution will prevail over all other laws. You have a right to exercise your profession. When they bring in capping, if you feel that the capping is unfair, you have every right to move against such an order before a court of competent jurisdiction and challenge the order of capping. Do not say, I won't obey this law because it comes in. Under the Epidemic Act, the government is authorized to take such steps as are deemed necessary to control an epidemic and the spread of the disease. Capping of charges is done in exercise of these powers. If you feel that you are not happy with this order, please feel free to challenge it before the court of law and let the court take a decision on this in its wisdom. I am telling you this on historical facts also because there have been some people who have challenged this and the courts have agreed that the doctors could charge whatever they felt. The capping was found to be unfair in certain cases. I'm not saying that in all cases, I'm being very clear. If you feel you are aggrieved, approach the authorities, either the government or the court, and see to it that the order is either set aside or amended. Don't sit and violate orders. Don't violate the law. You can always challenge it and get it set aside if you feel you are aggrieved, and the courts are always open to help you.
Vivek bhai, one more thing.
Yes.
In now this pandemic, even the barber is charging more. If you go there, the charges are almost very much higher side.
Yes.
This is one thing of the saloon and other whatever you say.
Yes.
Secondly, Vivek bhai, one more thing, like ophthalmic association, they are so strong that our consultant association, where I am medically insured, there they have a capping of 40,000 for your cataract, but this ophthalmologist association is so strong, they don't follow this. And this applies to their doctor colleagues also, I tell you. You know. So what I am saying, what I mean, I suggest, in such case, as the patient has a choice of a treatment, we also have a choice for the thing. Like there are certain senior doctors, who for the TKR, somebody must be taking 50,000, and some people they take 9 lakhs also, which I know, for knee joint replacement. It is their entire life. Secondly, as you are in the law, like old senior practitioners and all, with listen this all Khan chapters and all drug things and all, their fees are in crores of rupees, and there they take in advance, that very much well, better than me. So we can also refuse if we feel that to risk our life, is not worth. We can refuse the patient that this will be the fees, irrespective whether your insurance company pays it or it does not pay.
No, no. For insurance cases, this is not a question of capping. For insurance, you are well within your right to say that I don't want to accept this case because I don't agree with these fees. The question is when there is a law passed, a legal circular saying that there is a capping of your fees. Like in the first wave of COVID, there was a circular saying that for not more than 4,000 rupees per day it should be charged. That was in the first wave. Now, if that sort of a legal capping is brought and you try to tell the patient to pay you more, you would be fined on the wrong side. You will be caught on the wrong side of the law. So it would be actionable against you. But if you feel that you don't want to work in this scenario because you feel the fees are less, if you challenge the same order by a court of law and have it set aside, you will not be found on the wrong side of the law. That's what I'm trying to tell you. For insurance cases, there is nothing like a cap. You can always say, I don't want to work in this scenario. The question is when there is a legal capping, then your remedy is a legal remedy.
Now, what I meant exactly, I mean, another one more point. We also can refuse, considering, suppose if I am a senior citizen, I can very well see my own health first, rather than having this. And there are many other colleagues also who are available. And unfortunately, across India, we all people know that those so many doctors, have been unfortunately no more because of this COVID exposure. They have
Yes.
operated, as you very rightly said. But you will see that there are so many people, they do a planned surgery also, which can very much wait because of whatever reason. I don't want to say that. So the most important thing what I feel is the my point was that we can also refuse. I think we should be able to refuse that. Looking at the pandemic, we will not come to hospital OPD and clean. And I have already put a question in the chat that whether we are bound to attend the OPDs in a private hospitals.
See, the question is when there is a pandemic, the entire responsibility of saving is on the medical community. As an individual, I may take a decision that I do not want to work. But if the same decision is taken by all the doctors, who will control the pandemic? It is like saying that the army goes on strike in the midst of a war and says, look, we don't want to kill ourselves. Taking precautions. As an individual case, you say that I am a senior citizen with a comorbidity, you can be excused. But the entire medical community cannot be permitted to say that we will not handle a pandemic. In this sense,
No, I don't say that we don't handle the pandemic. My personal choice, like the other our colleague said, that regarding the fees and all, there is a lot of problem. And we doctors are only always targeted. Nobody sees the fees of a lawyer, chartered accountant, consultant, other people. We doctors are only in the eye of a people that we charge too much. In fact,
because we are the
the
ones who are
least
bringing
paid.
it live. See,
We are
chartered
the
accountant will
Vivek
not
bhai,
give it
we
live.
are the least paid, irrespective of your experience.
Correct.
Irrespective of what you are experienced, whether you have
Traditionally,
a experience of 4 decades or 5 decades, or whatever is your expertise.
See,
You know.
traditionally, doctors were not supposed to be paid anything. We are better off than our forefathers in that sense. I agree with you that fees are necessary, fees are required, but I repeat, I would never advise violation of the law because we don't agree with it. If you are not happy with a law which is passed, please feel free to move before the concerned authorities and have it changed, have it set aside. There are hundreds of options available. But if you say that, yes, there is capping and I want to charge more, therefore I will not follow that, you'll be found on the wrong side of the law.
Vivek sir, sorry, just that we don't get the wrong message. This all choice would apply in an elective case, not in an emergency scenario.
Refusal to treat in the face of a medical emergency is directly actionable against any doctor. And I would never advise anyone to step into this kind of a scenario and do something which is not only an offense in civil society, but is also a sin where you're causing someone to die just because you don't want to step in. Finally, to the end of the day, as doctors, we are dealing with human lives. We are not just cutting flesh and tissues and sewing them back. Ultimately, you may not be part of a uniformed force of the army. You may not be part of a uniformed police force. But please remember, as a doctor, you are dealing with human lives. Anything that touches life is very precious. And therefore, ultimately, you are even today an intermediary between God and the grave. The patient goes to the grave, it's God above who calls him. You are an intermediary preventing that chain from working. In the face of this, if you refuse to work, then I don't think it would be justifiable. Some people, for certain medical reasons, can say that I would not work, but the entire community cannot refuse to work in this scenario. I would not agree with this at all. I'm being very clear. I may sound very bitter, but then they always say that the truth is bitter. Never refuse a medical emergency for anything, even on the roadside. If you find a child with a peanut stuck in the throat, by the time he reaches hospital, he will die. He's someone's child. Be human. Do something there to help him out.
Sangeet sir.
Yeah, Vivek, thank you very much for enlightening us. And that was really a nice talk, which has helped all of our members. Thank you.
Thank you very much. My pleasure.
On behalf of the Bombay Orthopedic Society and all the viewers here, I thank Dr. Vivek Tilwani for his valuable time, valuable advice, and considerable effort which he has put in, not only for the Bombay Orthopedic Society per se, but even for a lot of my colleagues who I know he's really helped them out. Thank you very much, Dr. Vivek, and we shall soon see you in YROC Global, which is going to happen in March. So looking forward to that.
I will definitely join you. Thank you very much. And I hope I've been successful in putting everyone to sleep now.
Nobody's sleeping.
I think you opened our eyes. Thank you so much. And I wish all the viewers a very good evening and a good night. Thank you so much.
Thank you.
Thank you very much and good night.
Good night.